Hi, everyone. Thank you so much for joining us today. My name is Maanasa Kona. I'm an associate research professor at Georgetown University's Center on Health Insurance Reforms. Next slide. So for those of you who are unfamiliar with us, we are the Center on Health Insurance Reforms, a research center within Georgetown University's McCourt School of Public Policy. We conduct legal and policy research and analysis, publish reports, provide technical assistance to stakeholders and policymakers across the country, both at the federal and state levels. A large focus of my work at CHIR is on closing the gap between having insurance coverage and actually having access to healthcare services. And as part of this effort, we have teamed up with Leon Lowenstein Foundation to better understand the issues facing mobile health programs and how policymakers can support these clinics on wheels, as we call them. So during today's webinar, first I'll kick things off by briefly sharing our report findings. And then we'll invite in our expert panelists who actually have on the ground experience of either delivering or supporting mobile services. And then we'll spend some time opening up the floor to take some questions from you all. Next slide. So before we go into the juicy parts of this presentation, just some quick housekeeping details. We are recording today's presentation and we'll share a link of the recorded webinar to everyone who registered. And if you like what you hear today, please feel free to share the recording with folks in your network. And then second, the chat is open. I already see folks hopping in there, but feel free to say hi. And if you have any technical issues, flag that for us in the chat. We will be using the chat to post links for key resources throughout the webinar, so just keep an eye on that. And then we have plenty of time built in to take your questions. So submit your questions using the Q&A, not the chat, and put them in there. The chat can really get busy and the questions can get lost in there. So feel free to add your questions as we go along and we'll get to as many as we can during the panel discussion. So moving on to introducing our speakers. So today we're joined by Mary Kathryn Fallon, who serves as the acting co-director of the Family Van, as well as the Mobile Health Map, which I'm sure many of you are aware of. It's a website that has a resource of all of the mobile clinics across the country. Mary Kathryn oversees the finances and operation of the programs, has deep insight into fostering sustainability for mobile health. We also have Dr. Emma Lowe with us, who is the founder and medical director of the Street Psychiatry Program at the Connecticut Mental Health Center. The program provides mental health and addiction care to people living on the streets of New Haven and serves as a training site for medical students and residents. And then finally, we have Michele Stanek. Michele is the Associate Director of the South Carolina Center for Rural and Primary Healthcare, which works with rural healthcare clinics and rural practices throughout the state. They providing clinical services, workforce training, and research. Michele is currently spearheading a technical assistance program to strengthen mobile health across South Carolina. So it'll be great to hear from her later. But before we turn the floor over to these wonderful panelists, I want to briefly run through some of our research findings and then set the stage for the discussion. So the report I'll be discussing today is part of a year-long project at CHIR that was funded, as I mentioned, by the Leon Lowenstein Foundation. As part of this project, we produced 3 different resources that might be helpful to you. Last fall, we published a report synthesizing evidence from over 160 studies that looked into the impact of mobile health on various outcomes. Generally speaking, the report found that the mobile health can improve access, especially in terms of reaching hard-to-reach populations like rural populations. There's also evidence of improved health outcomes, reduced total cost of care. But obviously, that's just a snippet of what we found, and you can learn all about our findings in the report itself. And earlier this month, my colleagues Julia Burleson and Lila Sullivan looked into states' rural health transformation program applications and to try and understand how states were incorporating mobile. And they published their findings in a blog that we'll also put in the chat. And also you can say hi to Julia and Lila, who will be in the chat, and ask them any questions you might have specific to that resource. And then finally, moving on to our most recent publication and the reason we're all gathered here today. On Wednesday, we released our mobile health policy scan. This scan maps out what the current policy landscape looks like across states and then highlights some gaps and opportunities for both state and federal policymakers, but we'll focus on the state policymaker aspect for this particular presentation. Those who are seeking to better support and integrate mobile services, this provides some opportunities and suggestions for you guys. Next slide, please. So before we jump into all of the juicy findings, I think it's helpful to talk about what we mean by when we talk about mobile health, because this was a key question that we needed to answer before we jumped into our research for this project. There are over 3,000 individual mobile programs operating in the country, according to Mobile Health Maps database. And as a note, individual mobile program could consist of just one single unit or multiple units. So 3,000 programs means there could be even more units. And these programs are being run by just a variety of different types of operators, healthcare providers, community-based organizations, local health departments. And they're also diverse in terms of the services they provide, their operating style, and the populations they serve. So, for the purpose of organizing our thinking around both of the reports, we divided the different programs into 8 buckets of service type models that were the most prevalent in the literature that we looked at. So first, we have vans that provide primary care services, and this includes vans that provide preventive services as well, such as screenings and vaccinations. Then we saw 4 different models that provide different specialty services. We've got breast cancer screening is a pretty prominent use of mobile, and I believe it was because of a concerted push by CDC a few decades ago to make breast cancer screening more accessible. We also see a lot of dental and vision vans. Often these services are sort of clustered for specific populations, such as low-income school children or nursing home residents. Then we have vans that provide behavioral health care services, including medication for opioid use disorder treatment. And the recent easing of federal restrictions around mobile methadone provision has definitely helped expand mobile MOUD services. And then finally, in the research, we also saw 3 models of mobile healthcare that have a nexus with emergency services provision. So first, there's mobile stroke units, which were an innovative treatment model that emerged in Germany in sort of the 90s, and then it has been adopted by various academic medical centers across the country. The time it takes to initiate treatment is critical when it comes to securing favorable outcomes after a stroke, and so this model sort of leverages teleneurologist consults to initiate stroke treatment either prior to or during transportation to the hospital. And the last 2 models of mobile that are related to emergency response, and these 2 have been receiving a lot of policy attention, so you might be familiar with them already. So first, there's mobile crisis services to help folks who are in a behavioral health crisis and divert them away from the justice system and towards stabilization and treatment. ARPA funds and increased state Medicaid contributions have helped really expand mobile crisis services across the country recently. Then we have community paramedicine or mobile integrated healthcare. This is of course going to be a very massive simplification of a complex model, but generally speaking, the program focuses on expanding the role of EMS professionals and allowing them to either treat in place as in they respond to a 911 call that is not acute enough to transport the person to a hospital, and so they help them right in wherever they are called from. And there's also another submodel within community paramedicine that focuses on routine checks on older folks who've either recently been discharged from hospital, those who are high utilizers of EDs, to conduct some sort of basic health checks and services at home and to keep them from, having to go back to the hospital. So as we go through the presentation, you'll frequently see us organize our information around these service type models. So I figured it would be helpful to give you a little bit of a snapshot of what we're talking about. Next slide, please. So, turning over to our mobile policy scan, I think our goal in doing this was to understand what the landscape of mobile health policy currently looks like, what kinds of laws currently apply to mobile service delivery, what types of grants are helping fund mobile, in what ways are policymakers working to integrate mobile into the broader delivery system right now. So to do this, we reviewed federal and state policy actions generally enacted between 2015 and June 2025, which was our cutoff for our research. And we not only looked at legislative regulatory activity, but we also looked into grant programs, sub-regulatory guidance, Medicaid SPAs, and 1115 waivers. We made sure to look for policies that not just affect mobile services as a whole, but also policies that specifically affect one of those 8 models that we just spoke about. Our scan was really extensive and generated hundreds and hundreds of findings. But of course, given the wide array of sources that we were looking at the federal level, all 50 states, DC, I should add a disclosure that while our findings are probably extensive, they're not completely exhaustive. Pretty close to exhaustive, but not quite exhaustive. So once we gathered all these findings in our database, we spent a lot of time analyzing trends, similarities, differences across models, across states. And these are the findings that we've gathered for you in our report. They give you a lay of the land and then identify gaps and opportunities to move forward. Next slide, please. I think it might be helpful to start things off by looking at some sort of the broader trends that have affected mobile delivery. These are like what we call our trade winds or in the past decade. One of the things that struck us was the extent to which, in the last decade, mobile health policy has evolved sort of in fits and starts as a targeted response to specific and urgent policy changes. So, for example, during the COVID-19 public health emergency, mobile health became a practical way to deliver essential in-person treatments such as testing and vaccination services that obviously cannot be provided virtually. ARPA made funding available to FQHCs to expand testing and vaccination services, and a lot of them used this funding to add mobile units. In 2020, we also saw a rising interest among policymakers to tackle like access to behavioral health in response to rising mental health needs, as well as the ongoing opioid crisis. And we saw the creation of 988, and as well as the new Medicaid state option to support community-based mobile crisis intervention, which really helped kickstart the expansion of mobile crisis services across the nation. So while these developments are obviously a great step forward, it does demonstrate the fact that mobile health policy development has really taken place in these sort of siloed, fragmented ways. And it has resulted in some models, such as mobile crisis services, advancing, while other models have received sort of limited support. And one other major trend that we saw was that most grant making in mobile health has tended to focus on capital investments to purchase vehicles, which, as you'll see further down this presentation, does leave many mobile programs struggling to achieve financial sustainability in the long term. Next slide, please. So across states, we've identified four categories of policy action that are central to supporting the establishment of new mobile clinics and helping them sustain over time and integrating them into the broader healthcare delivery system. So first, you've got to build the regulatory frameworks that recognize and authorize mobile delivery, establish unifying principles, and provide appropriate oversight. Second, infusing capital and operating resources to support acquisition, maintenance, operation of mobile clinics. Then is developing reimbursement pathways so you can sort of slide away from having to infuse direct capital and towards allowing mobile services to sort of pay for themselves. And broader system integration of mobile health. And that sounds very vague right now, but I promise I'll give you more details about that as we go down into the presentation. And if there's one thing I'd want you to take away from this webinar, it's the concept of these four pillars, which are meant to serve as a guide for those of you looking to build a more comprehensive mobile health strategy. And these are the four buckets that we've organized our paper around. Next slide, please. So building a regulatory framework for mobile health. This is quite possibly the most extensive section of our report, and there's just a lot of nuance and information in there. We will not have the time to go over that in detail, so I'll just give you the broad brushstrokes here. I think the first foundational question that we needed to answer was why build a regulatory framework in the first place, and wouldn't regulating mobile health technically increase burdens or stifle mobile health? And to that, my answer would be yes and no. A well-designed regulatory framework for mobile health can really help standardize care delivery, establish accountability, helps it integrate mobile health into the broader system. It can make mobile providers visible, not just to the state, but also to payers, hospitals, schools, emergency personnel, local governments. And seeing the extent and types of mobile services currently being provided can also help states really understand what resources are available to them, help them in planning, and help them facilitate integration of mobile health by setting shared expectations around things like referrals and handoffs and data sharing with other providers in public system. But it is worth noting that establishing a regulatory framework to oversee mobile health is not inherently an enabling thing. When designed as a clear, proportional pathway, of course, it can reduce these sorts of transaction costs and facilitate payer and partner integration. But when the framework is fragmented across agencies, duplicative across service lines, unclear as applied to mobile settings, it can start to become a de facto barrier to entry and scale. With that out of the way, let's talk about what we've seen regulation in the mobile health space to look like. So first, we see many states that have pre-deployment approval requirements. So these requirements determine who can operate a mobile unit, under what authority, with what accountability to the state. States use a variety of different mechanisms to authorize mobile units that sit on a spectrum from low friction notification registration requirements to full facility style licensure. Very few states create pre-deployment approval requirements for mobile services as a whole. California is an exception here, and we'll get to that in a second. Most states, on the other hand, mostly require prior approval and authorization for individual models of mobile healthcare delivery. You'll see examples in our report of states establishing certain prior deployment approval processes for community paramedicine, for example, mobile crisis services, dentistry, MOUD, mobile stroke. States really vary widely in terms of how their pre-deployment approval processes actually work on the ground. For example, most require annual renewal, some require renewals every 2 years. States also require operators to submit a registration fee, and the amount can vary. For example, Oklahoma requires mobile dental clinics to pay a fee between $200 and $400, and Connecticut requires an annual $200 fee for EMS agencies seeking a state license to operate a community paramedicine program. Some states also require mobile health operators to submit an operational plan that has to be approved prior to launch. For example, Minnesota requires mobile screening and evaluation programs to file anticipated locations of practice, schedules, and routes. Moving along from laws that require pre-deployment approval, we also see that some state rules specifically restrict where and how mobile services can be delivered. So these constraints can be at the service line level, so restricting where a mobile program may operate, which populations it can serve, or at the workforce level even. So conditioning where certain clinician types may practice, and whether they can provide services on mobile units or not, which can still have like an impact on the operations of mobile services. So we see state level constraints pop up most often in the context of mobile dental and vision services, and you'll find a variety of state examples in our report and of what these restrictions actually look like in detail. So it's worth making a note of the fact that mobile clinic operators can also face some local level constraints, local land use, parking, fire access rules, zoning. These can also materially constrain. We're obviously not gonna get into that in depth during this webinar, but you can find additional information in the report. So now that we've spoken about pre-deployment authorization, let's turn to what happens once a mobile clinic has been authorized to operate. So states use a range of tools that set minimum expectations to monitor compliance and create ongoing accountability over time, like having inspection authority to go inspect vehicles, baseline operating standards for the clinic. They also set some workforce requirements, some staffing requirements and training requirements for the staff, and background check requirements for the staff even. And then there's also data collection and reporting for a variety of reasons. It can be for public health reasons or for quality improvement, programs. So in this report, you'll see all of these requirements and the variation between state approaches. But before we move on to discussing the second of our four pillars that we described earlier, which is grant making and direct investment, I want to take a second to spotlight California's model on regulatory oversight of mobile. Next slide, please. So California offers one of the clearest examples of a state applying uniform standards across all licensed mobile units. The state requires all mobile clinics to maintain written policies governing the services they provide, including policies related to patient care, personnel training and orientation, personnel supervision, evaluation of services provided in the mobile unit. And they also require mobile units to ensure safe patient access, outline equipment maintenance requirements, require mobile units to have transfer agreements in place with nearby hospitals and clinics if there's a medical emergency. So throughout the regulatory framework section of our report, you'll see various examples of the way that California has created this sort of uniform approach to regulating mobile. Next slide. So moving on to the second of our four mobile policy pillars, money. So across states, we've seen policymakers use direct public investment as a way to support mobile health's financial needs. These investments tend to cluster into three categories. So the first is direct appropriations to specific mobile programs or assets. So basically earmarks. States sometimes appropriate funds directly to named programs or specific mobile assets. These line item investments are typically time limited and place specific, and they often function as capital acquisition or targeted operating support rather than as sort of a durable financing stream. In practice, earmarks are frequently used for safety net delivery, mobile primary care, dental care, screening, and for visible, discrete infrastructure purchases. The second, we've got grant programs. Grant programs are the most flexible and common way that federal and state governments can support mobile health. Funding via grant making has several potential benefits. You can fund multiple local implementations of a given model. You can impose reporting and performance conditions. You can pair funding with technical assistance and regulator support and help providers sort of integrate into the health system, like we discussed earlier. So we see grant programs for mobile. We see a lot of activity at the federal level, which we will not get into for the purposes of this particular webinar. But we also see several state examples, and we highlight those in the report. But the three common grant design features that we notice showing up regularly across these examples is first, states often use grant eligibility criteria and reporting requirements to shape program design, such as establishing response standards for crisis teams or requiring reporting of outcomes and feedback. Second, mobile is frequently treated as a modality inside a broader initiative rather than as a standalone program category. It's usually like an allowable use of funds, essentially. And then third, grant making is often paired with an explicit policy goal of reaching rural, underserved, otherwise hard to reach populations, which really demonstrates that improving access for these populations is one of the key impacts that a lot of these states establishing these grant programs are seeking for mobile delivery. The third big way that we've seen public investments, appropriations to state agencies to support them in delivering services either directly or indirectly through contracts or other mechanisms. This is especially common in the behavioral health crisis space, and when states step in to provide or procure high needs services to meet certain specific population health needs. So, for example, Arizona authorizes its Department of Health to contract with public and nonprofit entities to provide primary healthcare services through mobile medical clinics to indigent and uninsured Arizonans in rural areas and in medically underserved areas. A handful of states have also used tax incentives to support mobile health delivery, and these we treat them as related but conceptually separate from, direct investment. Tax incentives are not direct capital infusions, but they can materially affect the total cost of ownership and operation for mobile units, obviously. So, for example, Minnesota exempts certain FQHC-operated mobile units providing medical and dental services from taxes on gasoline and from certain sales taxes on the vehicle. Next slide, please. I also want to take a second to highlight some of the work Oregon has been doing on the direct investment side. Oregon is a clear example of a state treating mobile health as a broad platform and using grant making to expand their mobile capacity. In 2022, the legislature directed the Oregon Health Authority to convene a mobile health advisory committee and collaborate with them to develop a mobile health unit pilot program. The state appropriated $1.7 million, 2023 to 2025, and then $1.6 million, 2025, 2027. And in addition to administering the pilot program itself, the Oregon Health Authority has also commissioned an environmental scan to help the state understand the current characteristics and regions of operation for mobile clinics. This is obviously going to be a key step in them developing a comprehensive statewide mobile health strategy. Next slide, please. So moving on to the third pillar, let's talk about where insurance fits into all of this. So as we've discussed, mobile health programs require capital to acquire and launch a unit, but their long-term viability depends on their ability to generate dependable ongoing revenue. And billing insurance for mobile services is a way to get that predictable payment stream for many operators. Reimbursement policies can deeply affect the functioning of many mobile programs. Payers determine whether a given service is covered when delivered in a mobile setting and whether any special site of service constraints apply. Unfortunately, payer billing systems and enrollment rules are not always built with mobile services in mind, which can create administrative complexities for operators. I know the slide says Medicare here, but in the interest of time and the fact that today's conversation focuses on state policymaker strategies, I'll skip that. Move on to Medicaid. We see in our scan that Medicaid is one of the most popular levers for mobile-specific policy design, especially when it comes to mobile crisis and community paramedicine. One of the most direct ways the states have supported mobile delivery under Medicaid is by defining a mobile model as a covered service with explicit standards and provider requirements. We see this most often for mobile crisis services. But coverage alone is, of course, insufficient to ensure sustainability. Fee-for-service payments often cannot cover the operational costs of delivering mobile services, and we see states are starting to explore different strategies and alternative payment methodologies when it comes to mobile services, like establishing bundled or per diem payment rates. A couple of states have also started using managed care contracting requirements to embed mobile delivery into the broader delivery healthcare delivery system. So, for example, Virginia requires its managed care contracts to include provider agreements for mobile vision services for eligible children in school settings. These actions matter because mobile providers often operate at the edge of standard network contracting, and managed care related levers are one of the few tools the states have to ensure that covered services are actually available. Turning from Medicaid, I want to briefly touch on private insurance. As the primary regulators of insurance, states do have a key role to play in shaping how state-regulated commercial plans, which admittedly does include many large employer plans regulated by the federal government. It helps them, but for the state-regulated plans, it does shape how they cover and pay for mobile services. But state policy in this space has sort of been thinner and more model specific compared to state efforts related to Medicaid. And rather than creating a general reimbursement framework, states more often intervene through targeted coverage mandates and through consumer-facing protections that govern cost sharing, prior authorization, or balance billing for services on mobile vans. Next slide, please. As we're talking about how states can support mobile delivery through insurance reform, I want to highlight some recent legislation we've seen come out of Arkansas. In 2025, Arkansas enacted legislation that facilitates coverage and reimbursement of all mobile models across state-regulated private insurance plans and the state Medicaid program. And they're required to cover any service delivered in a mobile setting as long as the service is otherwise covered when delivered in another setting. So this obviously creates a bright line expectation of coverage of mobile services. Next slide, please. Moving along to our fourth and final pillar, system level capacity building. This is relatively rare, but states are slowly but surely starting to treat mobile health as a delivery platform that must be understood, planned for, integrated. So in practice, this has led to state legislatures and executive branches commissioning reports to map the mobile landscape, identify gaps, create shared learning and quality improvement infrastructure, formalizing coordination mechanisms that connect mobile services to crisis systems, child welfare systems, other state-run systems. And this systems level work is hard and is, of course, very resource intensive, but it is really critical to build a sustainable mobile-wide strategy. We've already discussed Oregon's effort on this front, and later during the panel, you'll also hear what South Carolina has been doing on this front. Next slide, please. Moving along to recommendations, just based on everything I've said, none of this should come as a surprise. It is very much following all of our findings. Building platform level regulatory frameworks like California has done to kind of create clarity and ease of operations for mobile operators. Pairing grants with technical assistance on compliance and sustainability. So not, provide them with technical assistance during the grant period on how to achieve regulatory compliance and maintain regulatory compliance, as well as to how they can achieve sustainability once the grant period expires. As I said, using Medicaid and leveraging mobile appropriate payment reforms, managed care integration to support and expand mobile. Aligning commercial insurance rules, whether that's integration with network adequacy standards or having coverage requirements, bright line coverage requirements like Arkansas does. And then finally, of course, building durable state coordination capacity so you can inventory and understand what kind of mobile vans exist, what are they doing, where are the gaps, and then to create standing bodies, which can sort of provide long-term support and oversight for the state's mobile health strategy. So I've thrown a lot of information at you, so I'm going to turn the stage over to our wonderful panelists. Once they join me on the screen, we can dig in a little bit deeper and hear firsthand about the challenges and opportunities mobile health programs are facing in our states. All right. Hello, everyone. To kick things off, I want to direct a question to Dr. Lowe and Mary Kathryn Fallon. You both oversee mobile health programs in your community. I was hoping you could talk us through some of your pressure points, specifically what policies have been creating barriers or have helped accelerate your ability to deliver mobile healthcare in your community.
Thank you so much for the wonderful overview, first of all, and for having us here. I can speak briefly. I am, as you mentioned, medical director for a street psychiatry team, and we deliver mental health services to people who are unhoused in an urban setting in New Haven, Connecticut. Our program is very graciously funded by the state of Connecticut, the Department of Mental Health and Addiction Services. It was initially funded through a grant through SAMHSA, but it was then absorbed into the state's operating budget for mental health, which is really great, I think. So I'll start with that positive that we're able to be funded sustainably, at least for now, like given the current politics. But so we don't have to apply for grants every year. We don't have to rely on billing revenue or anything like that. Some of the pressure points and difficulties with that we're facing, I guess, would be uh, some of the requirements that we face as a mobile health team are the same requirements that in office brick and mortar clinic has to do. So, for example, if we're doing an intake for an unhoused patient in the community, we still have to do all of these intake paperworks and legal requirements, exactly the same requirements for a clinic. And unfortunately, as you might imagine, someone who's on the street in this kind of setting is not going to be able to complete like something that takes sometimes 3 hours to do a behavioral health intake. And so we face that as a big barrier. And then just speaking more broadly for other teams across the country, we're one of the only teams I know that is fully state funded. A lot of other teams are funded through the grant ways that you mentioned, which rely on certain cycles and certain requirements and is not like fully sustainable. And billing, which we rarely can ever do, unfortunately. Like we don't rely on billing revenue, but it's a barrier for other programs starting up because they're not able to bill for like what we often do is like engagement encounters on the street where we're working with someone trying to build a relationship. That's not really like a full healthcare level visit, so we can't bill for those. Even the locations that we see most people at cannot be billed right now with our current legislation and CMS approvals because they're outside of a clinic setting. They don't fit into the point of service and the point of service code that was added recently. Point of service 27, place of service 27 is not yet active in our state. So a lot of like sort of logistical barriers to allowing for billing, even if it was like sustainable. So
Thank you.
Thanks, Maanasa. It's always a great pleasure to talk about my favorite subject, which is mobile healthcare. So thanks for having me. I worked in mobile healthcare for a long time now, and I truly believe that it's really an essential part of care delivery in the United States. And I sort of have a dual lens because I work at the Family Van right here in Boston, but I also work nationally through Mobile Health Map. And so we just celebrated 34 years of service. And even in our urban community at the Family Van in Boston, we're still seeing people every day that are using the ER as their primary care. They're not connected to healthcare. And we see this nationally at Mobile Health Map as well. So your report really is confirming what we're seeing, that mobile healthcare is reaching people, but policy and payments aren't keeping up. And so I think the first pressure point I thought of was misaligning funding and reimbursement. So after 34 years, the family van is, oh, my volume is slow. Sorry. Sometimes that happens. After 34 years, you might think that we're stable and secure, but that's not really the case. So we're deeply trusted and integrated into the communities, and we're fortunate to have Harvard Medical School behind us because they support a portion of our budget. They help with key infrastructure like parking, insurance, legal, IT, but we still have to raise about 3/4 of our budget every year. And we do that through gifts, grants, and special projects. So there's not really consistent pathway to funding. And so nationally, we're seeing like site of service confusion. It's unclear and confusing sometimes if a mobile clinic is recognized as its own eligible site or if it's an extension of a larger system or something else entirely. And the administrative requirements can be complex for smaller programs that even when they're saving the system money, they're not seeing those returns. So grant dependence and instability, chasing short-term grants, navigating shifting priorities of funders, detailed reporting requirements, many clinics without institutional backing, it's time consuming, it's difficult to plan long term. So mobile health becomes a series of short projects instead of like this ongoing piece that the community is relying on, which actually helps continue and to build and keep the trust that we've worked so hard to gain. And then limited reimbursement for the workforce that actually makes mobile work. Many mobile clinics have community health workers and patient navigators. And so, although it aligns with federal priorities about, prevention, health, and things, um, it's really hard to get reimbursed for some of that work. So, like I said, although the mobile health saves the system money, it doesn't always flow back to support the vans themselves. And secondly, I would say that another pressure point is that policies are written for fixed sites, not really mobile care. And by mobile care, by design, it moves around. And there's a common phrase in the industry that says, if you've seen one mobile clinic, you've seen one mobile clinic. So they're hyper local, they respond to the unique needs of their communities, and they're nimble and they're able to move around. So even if that means crossing county lines or state lines, licensing rules, scope of practice rules, billing rules are kind of tightly tied to state or jurisdiction, so that can make it difficult too. Even though it can be efficient to be right on crossing county lines or state lines. So I am encouraged to see all these states starting to think about mobile health as a core infrastructure, like Oregon, like you said, South Carolina, that we're going to hear from, Pennsylvania, Maine, Massachusetts. We're hearing from a lot of states at Mobile Health Map. And they're beginning to ask the right questions, like how many mobile do we have? What are they providing? Who are they reaching? What is their impact? And then, of course, they're like a core access strategy, so they're being recognized. And when states use that kind of planning, and maybe now through the Rural Health Transformation Program, we know between 48 and 42 and 48 states included mobile. But if they have intentionally integrate these mobile clinics into their whole plan, like for the long term, it can increase the access for people. So there's also a lot of industry-wide focus, Mobile Health Map, the Mobile Healthcare Association, Driving Health Forward, and just this week, the National Association of Community Health Centers just launched a new center for mobile too. So there's a lot of resources out there for states to use.
Fantastic. And that's the perfect segue for me to ask Michele. Michele, you've been tasked with scaling up mobile health care across South Carolina. I was hoping you could tell us a little bit more about how you've approached this effort. What are some of the policies and programs you've been able to tap into?
Sure. So we were asked back in 2021 to create a mobile health technical assistance center within our Center for Rural and Primary Health Care. It shows the power of just one well-connected champion. So we had one legislator within South Carolina who is really keen and sees that mobile health care is a solution to one of the solutions to improving access to care for rural South Carolinians. And so after we actually have a legislative proviso to do this work. And so we started back in 2021, really similar to Oregon, just sort of wanting to understand the landscape and an inventory of where those mobile health units were in South Carolina. So we just completed our third iteration of that environmental scan. We did one in 21, 23, and now in 2025. That really gives a good overview of not only the number of mobile health units, but what sort of populations they're served, the geographic reach, and the services they provide. But it was also critical to us in the center to really understand where the technical assistance needs are, so that we could start building out that technical assistance rather than just sort of going off what we thought might be happening. So we still use that, and really it informs how we're building out our capacity within our center. Another piece of that is, again, to that capacity building you referenced, Maanasa, is the grant making. So in 2023, we were asked by our state Medicaid agency, Department of Health and Human Services, to administer a $2 million grant program for mobile health development in the state. It was really targeted to existing mobile health units versus new mobile health units, and really to help them improve their capacity, but then also providing operating resources for them. So we awarded 18 grants for with that $2 million, and they range for about 80,000 to 200,000. That program ended in 2025. We're hoping to get additional funds to continue that work because we still see the need. But like I said, there are 18 different mobile health units were funded, and then we were able to evaluate the impact of those resources on their ability to actually use them and expand the services they provide, expand their geographic reach. There were some mixed results to that program, but we were really excited because we were able to again use that program to glean best practices to help enhance our technical assistance that we're providing. We provide really sort of across the board technical assistance, or those sort of, as you phrased it, the pre-deployment to those who are currently operating, but then also investing in areas to help them better target communities. So we're working with Clemson researchers at Clemson University to have more targeted places to go. As I think I said, they're not just being so opportunistic of where they park and go, but they're actually going to where they can make the most resources in the community. Our proviso is up for renewal this year, and we're very we feel like that will again be supported, and hopefully that comes with some additional funds to push out those awards to some of our currently operating mobile health units, because I think we've seen a lot of growth in mobile health in South Carolina, but there's a lot of opportunities for optimization of those mobile health unit services, and really tackling some of the problems that have already been addressed by the other panelists. I think right now only 20% of our 60 mobile health units are even attempting to seek reimbursement for their services. So they're still largely relying on, grants and the resources of maybe a parent organization, a health system, or university.
I've got my fingers crossed for you that you guys get more funding. But this is a question directed to all of you, and maybe we'll start with Dr. Lowe. What advice would you give to state policymakers looking to improve access to mobile health care? What is the one thing that you think state policymakers could change?
I think speaking to some of the needs that everyone has mentioned and to our success, I think that appropriations of funding that's sustainable for mobile health programs is really necessary to sort of prevent this distraction of like chasing grants, chasing this funding, relying on philanthropy and donations, relying on billing that's not really fully sustainable, even if it is possible. I think just having sustained priorities in terms of appropriations of funding from the state level would, enable a lot more programs to succeed and even be started from scratch. So
Yeah, absolutely. Mary Kathryn, do you want to go next?
Sure. Yeah, so some advice I'd give is to really understand your landscape of what's in your state right now. How many programs exist? Where are they? What populations do they provide? Create a state registry, or better yet, use Mobile Health Map to put your mobile clinic on there, and we can use that in an aggregate across the country. So, supporting your clinics and sharing standardized data, I think you can better demonstrate to payers and funders like what the impact is having. You can aggregate and identify gaps, like you said, Maanasa, and even create a stronger evidence base for policy. The advice would be to align the reimbursement and regulations with how mobile healthcare is actually working. Mobile care is treated, as a legitimate mode of delivery, not an exception, not a band-aid, but it's really part of the whole system. And, clarify that mobile sites are reimbursable, streamline administrative requirements, ensure the core mobile workforce, including community health workers, are being supported. And even more than that, like not just like you had mentioned too, Maanasa, not just supporting the purchase of a van, but like sustained staffing, data systems, community partnerships, technical assistance, all that kind of stuff I think could help.
Absolutely. And Michele?
Yeah, I would endorse everything that's been currently said, but I also think mobile health advice is for mobile health units either connected within an existing sort of bricks and mortar healthcare provider, or those outside, is to really get connected into the system of care within the communities that they're serving, so that really those referral relationships, those medical home relationships, to make sure that that the patients that they serve are really connected into the entire system of care. I think the data piece is really critical, is to be able to, from the beginning, plan for data collection. When we had these 18 programs, none of them were collecting data, even sort of basic process measures on what they were providing, and then the impact that they were having. So, like Mary Kathryn said, we want mobile healthcare to really show its impact. So to plan from the beginning, really that data collection, and then those other systems integrations, even those mobile health units that are owned and operated by some of our health systems in South Carolina, they don't have access to the electronic health record of the health system. So, they're not really part of that sort of data universe. And so I really make that a priority, is having the data HIT systems and the data systems. I know not everybody has that opportunity, but even those that don't necessarily plan for that in the beginning.
No, thank you, Michele. I know we only have 14 minutes left, and I want to definitely take some audience Q&A. Chris Simon asks, as a manufacturer of mobile health vehicles, what is the best way to contact organizations who need our product to start and grow a mobile health program, either at state or local levels? I'm opening the floor. Feel free to jump in, whoever feels comfortable answering that question.
I can give a plug for the Street Medicine Institute. This is only one of many national kind of partnerships and networks that provide mobile health, but the Street Medicine Institute connects a lot of different providers of mobile health, but mostly the practitioners themselves and the administrators of programs, mostly for unhoused folks. So I think that is a great resource. I think they're just streetmedicine.org as one way to reach out to them.
And I'll just say, using a lot of the resources that are out there, becoming connected to the mobile healthcare associations and the community, mobile health map, and of course, Driving Health Forward, all the organizations I've already mentioned, and NAC too. So there's so many organizations out there that can help support and are connected to the clinics already, or the people that are thinking about creating clinics. So that's a good.
And one of the attendees just said, go to the annual Mobile Healthcare Association meeting. Absolutely true. So moving on to the next question. Have you been seeing any mobile units being able to bill for services via remote physician or NP? I know CMS at this point doesn't allow it, but not sure whether there are any workarounds for it. Do any of your vans offer remote physician or NP that you're aware of? And are they billing for these services?
I guess I can try to answer that, but go ahead, Michelle, after me. But we don't have any remote services, and I've never tried to bill for that. But one of the barriers, I'll just mention, not answering your question, but one of the barriers has been that even if we had the ability, like the technological ability, which we usually do, to do like a secure telehealth session with someone, we found that on the other end, the patient oftentimes needs someone fully at the appointment with them to arrange the appointment, to arrange the technology, to make sure it's working, to make sure that they're, on camera and all these things that logistically it required a lot of staffing from our network partners, and it wasn't actually feasible. And when we had in-person time, patients would just wait for our in-person time. This was during COVID where we had trialed this out, but we really didn't get a high response for the telehealth option.
I can tell you, out of our 60 mobile health units, 12 indicated that they are providing telehealth services on the mobile health unit. And I do know of one that I believe is receiving reimbursement for that. How, I'm not sure, but that's something that I will now look into.
Great.
And I
Thank
do
you
think
so.
it's the
Oh,
way of
yeah.
the, yeah, no, I do think it's the way of the future. I think that, especially with rural health, as clinics get out into the rural health areas, they can combine telehealth with the services that they're providing. And I think that that will be a billing mode of the future.
We have more telehealth questions. Are you finding that telehealth for mobile is going to be an issue since some insurance, providers are no longer covering telehealth? I imagine the answer to that is yes, that would be a problem moving forward, especially for those that do rely on consult with specialists, I would say. Anything that anybody else wants to add to that?
No, I would just add that we in South Carolina have a pretty robust South Carolina telehealth sort of technical assistance center, this Telehealth Alliance, that again is legislatively sponsored. So they're very good, and mobile is one of the areas that they do focus on providing that technical assistance for getting equipment, getting startup. And really, they're the experts on sort of the do's and don'ts of billing. And I know that new modalities of care, including mobile, is one of the areas that they're focusing on.
Absolutely. Lisa from the chat says that they have a small mobile dental van. It's been very busy and run into large organizations getting local grants instead of her. And but she's the one that's actually seeing patients. And
Mm.
absolutely, those are the exact kind of problems that we highlight in the report and throughout this conversation. So thank you for sharing, Lisa. We have a question from Sandy. Is there any effort to create platforms for mobile medical services so that each instance is not custom or to establish a baseline set of services? Oh, so I guess, do you mean that each unit does, I'm going to interpret this as you saying that, not that each mobile van, what Mary Kathryn was saying, you see one, but to create more models that are more standardized. Has there been effort on this front and that you guys can speak to?
I think that's one of the reasons, not so much to like to have a sort of blueprint, but to share best practices and to say what are the facilitators of a mobile health unit. And I know that many folks within South Carolina do, as we call it, R&D, rip off and duplicate, models across the country, particularly doing that now around mobile maternity care. So they're looking at adopting what other successful providers of those services are doing. So they're not, we're not in the process now of creating a uniform sort of approach, but we're trying to inform to save folks from making sort of repeating mistakes that people before them already have experienced.
Yeah, and I would say to agree with Michelle, although the vans themselves are hyper local and responding to the communities, there are similar workforce models or services that they're providing. So getting together with clinics and finding out what those best practices are is definitely a way to sort of scale mobile clinics that are, more just some standardized recommendations that people can start with and then adapt.
No, absolutely. We got a question here that's could be seen as a follow-up. Do you see any problems with state level oversight? And I think just from a potentially missing what is critical to individual communities, putting my researcher hat on for a second, I think what we see with a lot of promising models for healthcare delivery is that once the model, you have this evidence establishing that it works, in terms of scaling it, you have to create some minimum standards. And it's just how things work. You have to recognize it, you have to define it in some way. Then it becomes a push and pull of, you don't want to stifle innovation and you don't want to stifle like local instances of the model's implementation. But at the same time, you have to then, to have to provide some supportive services, having some kind of baseline models and like some standardization helps with startup as well, because you have the starting point that you can come and look at and get some direction on. And then and we also highlight the importance of bringing together folks for learning opportunities and shared learning opportunities, peer learning opportunities across the board as well. And we think that there is some real value to that. So the tension is understandable. There needs to be flexibility for local level experimentation and implementation, responding with agility to the needs of the community. But then I do think that there is some room for some sort of state level or like, more formalization across models. I don't know if folks want to jump in on that.
I can say that between our first round of sort of giving those awards and the second round, we learned a lot about, for lack of a better word, who might be a better investment of those resources. So we did really sort of adjust sort of our selection criteria to reflect really where we felt like those awards were going to be beneficial to the communities that they were serving.
Absolutely.
Just a
Um,
quick comment on that, on
yeah.
scaling and everything. I feel like we've been talking about this for a while about like scaling our model to the rest of the state of Connecticut. And I've, been in touch with various people across the country on their models and similarities and differences. I think what's important is to do both the top down and bottom up approaches at the same time. Like the bottom up is like really understanding the local layout and the people who are invested and care about these programs actually succeeding, and where it will be actually augmenting the services that already exist. And then the top down is where like the resources and kind of like support come in. But I think without both, you might miss the mark in terms of what's needed in an individual community. And kind of speaking to your point, Mary, Kathryn, about like the hyper local kind of needs of a certain community, and like building that structure around what's already there and like augmenting what's already there in the infrastructure.
No, that's absolutely true. So Jordan has a question. To balance quality services and the cost of operating a clinic, have you found staffing or operating models that are most sustainable and easily replicable? I think that's a complicated question for anyone to answer, but if anyone wants to take a shot at it, we're still figuring it out. Is that the answer?
I think from what we've seen,
Yeah.
it in our environmental scan, it's the number one area of concern is really figuring out staffing models, staffing availability, so and training for staff. So we're still working on it.
No, that's helpful. Joe and Carol have some questions about federal level policy movements. Joe asks whether there's a federal bill on EMS treatment in place is not moving forward in a timely fashion. Is CMS in support or opposition? Unfortunately, Joe, at least I do not know of the vicissitudes of, federal policymakers on this front. So it's hard for me to predict what is happening and whether it will move forward, but we're watching it as closely as you are. Does anyone have any further insight into this particular bill on EMS treat in place that you'd like to share? All right. But yes, we'll be watching it, and hopefully we'll update you on LinkedIn and our socials when we learn more about federal bills. Lane asks, could you share a link to the evaluation of the grant program in South Carolina for more details and best practices, Michele?
I don't have a link, but we can certainly get that to you, Maanasa, and pull together our evaluation.
We're happy to share that with the webinar attendees as well. Carol asks, does anyone have a sense if HRSA will continue grants that support mobile health clinics? Once again, it is hard to predict what is going to happen at the federal level. But if anybody else has more insight, I don't know. But if anybody else has more insight into this than I do, please feel free to jump in.
I was encouraged because our street medicine partners in New Haven actually recently got a HRSA grant for expanding street medicine education. So I was surprised in a way to see that went through, but that happened this fall, and so they're starting to expand their street medicine program to certain residents in a primary care program to be able to train more practitioners in providing street medicine. So that was fairly recent.
Okay, that's very promising, and love to hear it. Unfortunately, that is about all the time we have for today. Thank you so much to our wonderful speakers and to everyone who tuned in, especially on a Friday before a long weekend. Please don't forget to sign up for our newsletter and follow along with this work. Maybe we'll provide updates on that EMS bill that you were talking about, Joe. Stay well and have a great weekend, and we'll make all of the slides and the webinar, et cetera, available to you guys on our website. So stay tuned. Thanks.